Welcome everybody. My name's Peter Wearne. I'm the chairperson of the Yarra Drug and Health Forum, and I'm really pleased to have such a star-studded lineup that's going to be presenting today based on the recommendations of the recent Royal Commission into Mental Health. And we're covering a lot of bases. Firstly though, and this is not an afterthought, but a really important thought and an important acknowledgement, I'm on Wurundjeri land, people of the Kulin Nation, and I'd like to pay my respects to the elders and the traditional owners of the land that I'm sitting on. And I'd like to especially pay my respects to one of the elders, Uncle Colin Hunter, who's a very close colleague of mine, a Wurundjeri elder. And we want to acknowledge wherever we are that we are on Aboriginal land and it is stolen land. And we will look forward to the day when reparation, understanding and reconciliation is truly established across this country. And a bit of a shout out to Stevie Thorpe and his great work that he's been doing on his podcast talking about the historical Warrigal River massacres in Gippsland in the 1840s. So again, we pay our respects to any Aboriginal or Torres Strait Islander people that are in the meeting today. And we stand together in solidarity with you, your culture, your cause. Let's end racism, eh? So today is my pleasure to introduce a number of speakers. I am definitely the froth on top of the cappuccino today, not the coffee, who are going to be sharing their insights and understandings of generally about the mental health system, but more particularly about the recommendations from the Royal Commission. Yarra Drug and Health Forum have got a theme currently around ending stigma and discrimination for people in health systems, especially drug and alcohol and mental health. And we've really flavoured it a little bit that way today, but speakers are going to speak about what they're going to speak about. They have no editorial censorship. The one thing I'd like to apologise for today is that our panel has no Aboriginal or Torres Strait Islander perspective on it today, and we would have loved to have had that. And I'll take responsibility for that. I just couldn't find someone who was able to speak from that community. And also, we don't really have a representation of the richness of diversity in our community from new arrivals and refugees speaking today. And I know this is a really big issue. We plan to address that in the future, that we will have those perspectives represented. But without further ado, I'd like to welcome Dr. Neil Coventry. Now, Neil is a distinguished psychiatrist and a distinguished mental health practitioner, leader. I won't call him a bureaucrat, but he probably is a bureaucrat in some ways. And Neil's main role now is the chief psychiatrist for Victoria. And Neil's speaking in that capacity, but also based on his year's experience. So it's with great pleasure I welcome you, Neil. Welcome.
Oh, thank you very much, Peter, and also thank you, Nick, for helping me. I'm a technophobe, so Nick's going to be helping with my overheads. As usual, I've presented, I've got far too many overheads, so I'll just quickly romp through them and try and pick out the highlights. And using your coffee analogy, I hope I'm not the bitter coffee grounds at the end of the cup, really. It's a sweet cup of coffee this time. It's really good news. As Peter started, I'd also like to pay my respects to the traditional owners of the lands, wherever we might be meeting across Melbourne or Victoria, and pay my respects to elders past, present and emerging. I'd also like to pay my respects to anyone with lived experience of mental health and alcohol and other drugs, both as consumers and carers, and also to acknowledge our extensive workforce, both the clinical and non-clinical workforce, who do fantastic job under difficult circumstances. So I'll quickly launch into my presentation. If I could have the next slide, Nick, what I'm going to be trying to do is give you a bit of a framework of the Royal Commission, which is a massive 5-volume report. If anyone's actually downloaded it, I don't suggest you do, but it weighs something like close to 15 kilograms. I'm in my office now, so I should actually have the copies to show you. It is very extensive, and it's got 65 recommendations across its 5 volumes. Unfortunately, there isn't one single volume that summarises. The executive summary tries to do this, but unfortunately you've got to do the deep dive. I apologise for that on behalf of the commissioners. That's probably the only way you get a sense of the reform agenda, which is incredibly expansive. It's already being implemented. There was an interim report that was a year ago, and now the final report, which happened, oh goodness, beginning of March this year, and the government has committed to implementing every recommendation, and also there's now a funding arrangement, which is really good news. So I'm just focusing on trying to give you a bit of a framework about the architecture of the report and the reform, so you can hopefully, when you do your deep dive, make some sense of it. If I could have the next overhead, thanks, Nick. So I'll try and focus on some of the key areas, and again, I won't do this justice given our time, but I'll try and skim through it. So 6 key areas. So one area is around community base as its core. So while we've been concerned, particularly in the specialist psychiatry field, about inpatient mental health beds, this is really focusing on reform across the whole system, with its basis being strengthening community-based services, and I'll speak a bit more about that later on. It's also taking a very broad approach, so it isn't just looking at the specialist areas, but it's looking at generally mental health and well-being. So it's not just the area I, as Chief Psychiatrist, cover, which is only a small percentage of people needing mental health service. It's looking at general mental health and well-being, particularly suicide prevention, and trying to look at services where people live, where they work, where they learn. Supporting all Victorians to experience their best mental health and wellbeing. So it's as we call in government bureaucrat speak, whole of government joined up response. So mental health and alcohol and drugs is everybody's business, not only the specialist areas. Looking at new system foundations. So one that you'll be probably interested in will be setting up in Victoria a mental health and wellbeing commission. Some other states and jurisdictions have got this, but we haven't had this in Victoria. And the interesting thing about this is one of the commissioners must be someone who has lived experience, which is fantastic. Also, in doing reform, you've got to have evidence base and research. So there's going to be support for research to continually improve mental health treatment, care and support. One example being the Collaborative Centre for Mental Health and Wellbeing, and also an innovation fund to be highlighting pilot innovative approaches. And then finally, developing this as a system for the future. We're talking about massive reform, so we're talking probably about something that at least is 10 years, maybe 15 years work to try and restructure. If I could have the next overhead, thanks, Nick. So what I want to move on now is to talk about a new mental health and wellbeing system and talk about the community-based services. If I can go on to the next slide again, thanks, Nick. So again, I'll skim through this, but it's just really telling you some of the architecture. So it's sort of looked at as terms of a number of levels, what we used to call in the old system tiers of services. But the bit that you might be interested in is new local services. There's going to be 50 to 60, a massive number of new local services for adults, and we used to call them aged mental health, and now it's just a nicer term, older adults, in addition to services dedicated for infants, children and families and young people. That's close to my heart because I'm a child and adolescent psychiatrist by training, so very important to try and look at continuities from birth onwards, really, or pre-birth. And this is supporting people to get access to services close to their homes and in their own communities. It's going to be a range of service providers, so this is complementing the specialist area mental health service that I cover, but we'll be including NGOs, headspace centres, some hubs for infants, children and family, community health centres as well. So it won't be maybe as precious as we've been in the past about where services need to be delivered. We'll still have our area-based services for adults and older adults and services for infants, children and young people that'll be really at the specialist end, and that will be done as a partnership. So again, the significant change to what you've probably been used to is these at the moment are governed by health services, as in big hospitals. It won't be just the hospital governing. They will be in a partnership role to deliver these services with an NGO. That's a significant change, I think, and it probably means it brings in the sort of support rehabilitation sector that had sort of been separated. So Peter's just mentioning, I'm certainly very happy for these slides to be sent out to everybody who's enrolled. We'll also be looking at some state-wide services, including people who are affected by trauma, but particularly for this audience, people who are living with mental illness and substance use and addiction. I'll say a bit more about this because we'll be setting up some particular centres of expertise within emergency departments for this cohort group that's really been left out. If I can have the next slide again, thanks, Nick. This is really sort of summarising what I've been saying, that we'll have two aligned systems. The system for children and youth will be ages roughly 0 to 25, although having said that, there won't be strict age criteria and eligibility criteria, particularly in the child and youth sector, where you might want to be offering services to infants, families, very young children, where they might not have a diagnosed mental illness, but they certainly have mental health issues and you need to intervene earlier. And to have some fluidity, so it won't be a sudden cut-off when you turn a certain age, you're eligible or not eligible. The idea is to provide continuity. But at the moment, we've got a bit of a hodgepodge of some services being up to 18 and some being up to 25. So what we call a CAMS, Child and Adolescent Mental Health Services, or a KIMS, Child and Youth. We're going to have a standard model. But other interesting parts of this, I think, for this audience will be expanded service offerings, particularly around psychological treatments. One of the criticisms that was said many times the Royal Commission was the focus on medication and not psychological supports. And some of that's driven, unfortunately, by the sort of crisis nature of what's being provided. But it's been a serious deficiency, I think. And as I said before, there will be, this is sort of early work, so I can't really tell you a lot of the thinking behind it, but there'll be a number of hubs to do with mental health and alcohol and other drugs, so that each region will have a hub specialising in this, which will also be linked in with their emergency departments. If I could have the next slide, thanks, Nick. So this is just going to really be expanding on what I was saying, that the current arrangements that you would know about with your local mental health services will still pretty much be the same. There's a few changes, and look, I won't go into this, it's probably getting a bit granular, but there's been a bit of anomalies, particularly for anyone who lives around the Epping area with Epping or the Northern Hospital, which has its mental health services provided by Melbourne Health. Don't ask me why. It's a bit of a weird arrangement. So when we've got services like that where there's sort of in reach from another region, that will be changed so that it's a clearer governance structure. There's a couple of others as well. The other change that might be relevant for you is a change with Origin and the Royal Children's Hospital in the west of Melbourne, where the Royal Children's will be only providing mental health services for children aged 0 up to the age of 13. 13 and above, their service will be provided by Origin, who are currently doing 15 above, so they'll slip down to 13 and above. And the other thing that's perhaps relevant, how this will roll out, I'm not sure at the moment, but you've probably been as frustrated as I have with the catchment area. Sometimes I think that's half my job, is to, almost like sit with the Melways or Google Map to try and work out which side of the street you're on, and odd or even numbers, and which specialist mental health service you get to. While we still will be trying to focus on people getting services closer to their home, closer to their work, we won't have the strict catchment boundaries. In other words, you won't be able to be excluded from getting a service because you live in the wrong suburb or the wrong street in a suburb. Clearly we'll need to do this sensibly because we don't want people falling between gaps, but it's been one of the criticisms that the catchment areas can at times be interpreted too rigidly, that ends up people being denied a service. service. And I'm sure you're as frustrated as I've been with this. If I could have the next slide too. This is really talking about the changes to regional commissioning. And this is a work in progress, but what's going to be set up is regional boards who will be basically understanding and planning local services. They will eventually be the funders, the people who provide the funding to the mental health services and have monitoring and have oversight of the arrangements that people might have between a health service and an NGO. They'll also be responsible for undertaking workforce planning, establishing resources and directories. They will also have the opportunity to trial pilot innovative approaches. This will be done in a stage process, although it's happening pretty rapidly. There'll be some interim boards set up in the next couple of months, and then eventually over a number of years, this will be how all mental health specialist services will be governed. This is quite a significant change from the current arrangement. If I could have the next overhead, please, Nick. And also the Royal Commission was looking at some different approaches to quality and safety oversight. So I still have a job as Chief Psychiatrist, but it won't just be me. I'll be looking at accountability and compliance. But there's also going to be a new mental health improvement unit, which will be in the department, but in a separate part, not within my office. It'll come under Safer Care Victoria, who are responsible for quality and safety and systems improvement in general health. They will also take on mental health as well, but it will be more sort of a systems improvement strategic lens that they'll be using. In addition to that, by the beginning of next year, I think I've got the timing right, there'll be a new Mental Health and Wellbeing Commission, and they will be separate arm. They won't be part of department or government. So the idea, I guess, is to, inverted commas, make the bastards honest, to really be providing independent systems-wide oversight. They'll also have the responsibility of investigating complaints that currently go to the Mental Health Complaints Commissioner. Her role will actually sit within the Mental Health and Wellbeing Commission. Next overhead, thanks, Nick. I'm moving through this incredibly quickly, I apologise, but I wanted to just look at beyond the system, some of the enablers. So if I could just quickly, Nick, move on to the next overhead. One of the focuses is going to be on a systems-wide approach to suicide prevention, particularly around aftercare, looking at the opportunities when someone presents with self-harm to emergency departments and making sure that they actually get linked in with peer supports into ongoing support for a period of time after their presentation, which is, when they might be most vulnerable. The other change will be having a frameworks document. So we're looking at accountability about what we're actually trying to achieve, rather than just throwing money and hope it sticks and does something, to actually try and monitor what it is we're actually wanting to see in terms of outcome and how we approach good mental health and wellbeing. So this is like not separating the specialist service from tier 1, tier 2 services. Looking at networks of community leaders in each sort of local community. As Peter was mentioning at the beginning, the focus on anti-stigma, particularly for young people with mental health issues, anti-bullying programs in school, but more broadly around anti-stigma, which we know is one of the important barriers to people actually getting appropriate service. Also to try and protect people from any mental health discrimination. I'll move on. So again, I'm romping through this very quickly because it's a massive number of volumes. If I could see the next overhead, thanks, Nick. Just a few headline recommendations, really, trying to look at culturally safe and appropriate care for people of Aboriginal background and their families, including 2 new innovative pilot projects of healing centres for the Indigenous community. Also to look at the differences between metro services and rural regional services, and also supporting digital service delivery initiatives and virtual assessments as we've had to do during the COVID lockdowns, focusing on diversity diverse communities, particularly looking at the LGBTIQ plus community, helping people in that community to be able to navigate, and obviously the stigma and discrimination is really important. Now, something that's very close to my heart, one of our challenges in mental health is we have so many people who are homeless because of their mental health concerns. So there's been a focus, not enough as far as I'm concerned, but at least it's a first step to acknowledge that we need to have support home, specialist home services provided for people living with mental illness who need ongoing intensive support rather than just have them competing on the open market. They're a particularly vulnerable group, and we compound their mental health problems when clearly they're homeless, and it's a terrible blight, I think, on our system. Also looking at the justice system, we know some of our mental health patients unfortunately access the justice system. I need to say a sort of caveat with this, that the majority of mental health clients are actually victims of terrible things that happen in the community rather than perpetrators, even though they get a lot of attention in the rare cases when they're perpetrators. Much more commonly, they're actually victims of this, but certainly can end up within the justice system inappropriately. Getting to the home stretch, so I'll quickly move on to the next overhead, Nick, if I may. How we want to have this as sort of foundation is to, as I was saying right at the beginning, having people with lived experience front and foremost, that's the single most important thing, I think, to drive service improvement and safety and quality. So having leadership positions for people from lived experience, this would include AOD experience as well, even setting up a new agency that's going to be led by people with lived experience. Also thinking about the role of young people who are carers. The other thing I should say is a new Mental Health Act. This is causing me some anxiety, and part of the reason why I can't be here, unfortunately, Peter, for the whole of this fantastic forum. We're developing a new Mental Health Act. The time frame is ridiculous, really, so it's got to be done within a year and a half, actually within a year now, so that we're talking about 2023, so the year after next. And the idea is that this will drive some of the reform. So this is a massive piece of work. Part of the brief with this is to try and minimise the use of what we call involuntary treatment, to take away people's rights, how we actually manage all of this. So this is going to be a very important piece of work. Unfortunately, with the time frame, probably not the consultation that's really required for this, but the idea, I think, of the Royal Commission was to use this as one of the drivers. We've also got to look at a workforce. This is going to have a massive increase in our workforce, and that's going to be a struggle. I'm sure it is in the AOD space as well. So try and think about how we support the workforce, having a workforce strategy, try to look at the workforce needs now and in the future. This is a big concern for me in the specialist mental health area because we've got an ageing workforce and we don't have the multidisciplinary workforce that we really need. But we're also very interested in using much more peer workforce, and we've got some really good examples of success with that. And as I said before, reducing the use of seclusion, restraint and involuntary treatment. I'm just aware of our time, and I wonder if I might just skip the last overheads. And I was going to talk a little bit about children and youth, but because I can't stay for the panel discussion, Peter, we've only probably got a few minutes, but I'm happy if people would like to fire any questions at me.
Thank you. Yeah, thanks, Neil. Look, I know it's a lot to go through. So the first question we've had is based around the area of discrimination and stigma experienced by people with mental health and alcohol and other drug issues.
Yep. Look, I think we would all recognise, Peter, and whoever asked that question, that is an absolute barrier, and it actually stops people even coming to get any help. We make enough difficulties with people trying to navigate the system, which is so confusing. But we also don't want stigma to be a reason that people don't actually seek out this. And this has partly why this whole reform, Peter, is really a whole of government reform. So it's not just the specialist area. And I think the great advantage at the moment is that, I've been around for a while, so I can remember when I first started training, alcohol and other drugs was actually part of mental health. Then we separated. Now we're coming back together, which is as it should be. I think we can learn from the different models, and also, I guess, to try and avoid our own internal stigma that we can have. Mental health workers can be stigmatised about people coming with alcohol and other drug issues, likewise maybe in the AOD sector. So I think working collaboratively, we need to be modelling how we're overcoming that sort of stigma and helping people to reach out, and that's why it needs to be a whole government approach. And I think we're seeing some good stuff in the media about how people are more comfortable talking about their own personal experiences if they feel able to do that, to try and minimise that this is something that we need to be hiding away or frightened about.
And the other thing, Neil, not trying to rush you, but Vanessa raised a question about the role of peers that are employed around their conditions and opportunity to lead and really being valued, I suppose.
Look, that's a really good point. And I think we're still on a learning curve, to be honest, Peter, with this. And I can certainly speak of my own direct knowledge of how important this has been to mental health services, really. But it's got to be not sort of tokenistic. It is difficult. I think one of the questions was, how do we train up and support people? Because it's an incredibly difficult task, I think, to be a peer worker. The most successful models that I've been aware of is where people are working alongside the other staff. So it's actually integrated in the service. It's not an add-on that you think about when someone needs it. It's actually something that everybody gets. It's part of sort of business as usual, routine care. And I think we've seen some extraordinary impacts in a way we never would have imagined in mental health. And I can't speak for AOD, I'm sure it's the same there. So having, that's another way of breaking down stigma and discrimination. But I think it's an important workforce to be training up skill, taking that leadership, but making sure it's integrated as business as usual. I get really concerned when it's seen as a sort of subspecialty add-on, and the ones that I've been involved with particularly have been at Alfred Child and Youth Service, where it is just business as usual that a peer support worker is part of the team that everybody has offered to them, and it's been fantastic, really.
And one last question, Neil, is around the whole issue of dual diagnosis. Do you see a lot of hope around the embracing of dual diagnosis?
Yeah, look, and thank you, Lynn, my friend. Lynn, a good esteemed colleague, asking that question. And Lynn would know, I try to be optimistic about this. I guess in my sphere, I sometimes hear about the failures about this, and, it can be a real problem when people have dual diagnosis, dual disability. It can be a bit like everyone tries to pass the buck and it's someone else's problem, rather than it is just one of the many complex needs that people are needing to experience. And it needs to be integrated in the service treatment plan with the person and their family and carers, not just something that we all sort of slice off a bit of the pie. I think we've seen some terrible examples when people try to do this and don't do it well or separate it. And certainly the dual diagnosis services have been one of the important cultural shifts with this, but I think we need to do a lot more. I come from a child psychiatry background, so a lot of the things that adults regard as disability, I don't in child psychiatry, autism spectrum being one. It's just our core business in child and youth psychiatry, but maybe not so much in adult psychiatry. So we need to skill up people, but I think what we absolutely need to overcome is this separation about what's disability, what isn't, and being smarter, I think, about working with NDIS and all the other support services and NGOs, as all of us sitting around the table trying to come up with a comprehensive, robust and inclusive plan, rather than people are doing little bits of the pie, and it's certainly not integrated. We also need to look at accommodation issues, because it really bothers me that we fail sometimes with that social support and accommodation, and people end up in specialist mental health services where I'd have to say, when they have a dual disability, it is not the right environment at all. We probably, unfortunately, make this situation worse without meaning to, and it's terrible that we're using that sort of part of our service system to provide accommodation for people because we can't get the appropriate accommodation in the future. So I'm cautiously optimistic, Lynn and others, that we can actually make a difference. We've already done that journey, started on the journey, but we've got a long way to go.
Look, Neil, I'm just going to have to end it there for you. But Neil, on behalf of everybody here, I think we owe people like yourselves a great deal of respect and debt because of the work you undertake on behalf of the Commonwealth, of people in this state, and we wish you every strength and every success moving forward, and we thank you for today. So we'll do a Zoom, whatever it is, and say thank you and good luck with the work that you do.
Oh, well, thank you very much. And also, I'm really looking forward to working back with my colleagues in the AOD sector, which is sort of how I started in psychiatry, never understood why we got separated. So hopefully we can be a happy family and provide much better integrated service. Like, at the end of the day, we're doing this for outcomes for our clients and their families and carers, really. So I'm really looking forward to this. It's our moment of glory under the sun, and the government's very committed to this. So now's the best time, really. We're well overdue, but I'm really cautiously optimistic. So thank you, everybody, and look forward to meeting with you again, Peter and others.
Thank you very much, Neil. Now, Heather, you're going to jump in and make a comment. I'll save your comment for your presentation. Is that okay? I'm just conscious of time, but we have the benefit of having Heather Pickard from SHARC, as the CEO from SHARC, as one of our presenters. Now, Sam Biondo, it's over to you. Now, Sam needs no introduction, but I'm going to introduce him. Sam is a esteemed and valued colleague, a great contributor to the well-being and the justice frameworks in Victoria over 4 decades. Sam is also currently the CEO of VAADA, which is the peak body for alcohol and drug services in Victoria. And Sam's going to be presenting on that basis, but also on the basis of his years and years of experience in being an advocate and a worker for social justice within Victoria. So over to you, Sam.
Thank you, Peter. You're too kind. But let me begin by saying that I'd like to pay my respects to the traditional owners of the land we're on, wherever we may be, and I also pay my respect to Aboriginal elders, past, present, emerging. And look, it was a great presentation by Neil. It just gave you a flavour of how complex, deep and enormous the challenge of reforming the Victorian mental health system actually is. In fact, what I'm going to speak about today is try and focus on stigma, human rights as a key aspect of the driver for reform, and they'll be a key aspect that indicate its success or failure. And I don't say that lightly. I think it is critical that if we create a new mental health system which is humane, human rights has to be at the centre of it. I was also interested in Neil's comments around integration of AOD back into mental health. And this is a huge topic of conversation in my world. And it's very interesting to note that AOD escaped from the grips of mental health because of the failures of mental health to address alcohol and drug issues within that system. I know there's a lot more effort and hope being expressed about how it can be integrated back in, and that will be the topic of many conversations, and I suspect great progress and great leaps forward. Now, where do you begin speaking about the Mental Health Royal Commission, size and breadth of its potential impact? I think to state the obvious, the Commission has set out a transformative reform vision. It's got the potential to create a world-class mental health system. And I don't say this lightly. I think the amount of effort and thought that's gone into the thoroughness of its consultation is an indicator of how serious this endeavour actually is. I'd like to go a little bit beyond this and say if it's done well, then it should also transform the way we do business across our social welfare landscape, including allied systems such as alcohol and drugs, justice and corrections, housing, education, health, and more. And this is because mental health is not just the responsibility of mental health system. It's definitely part of everything else, and it's in everything else that we do, and it's in many of our other systems and the way in which they respond to their clients and work with people, and the way in which we interact with one another. So clearly mental health is located across the whole of life spectrum, and it goes from cradle to grave. It's an obvious interplay with the social determinants of health and other institutional and other cultural factors. Basically, mental health is part of us all, and most importantly, I'd say that the collective mental health of all of us is a reflection of the health of our society and community. And this is critically important to understand. If we want a decent community, we've got to have decent mental health. And if we have decent mental health, we have a decent community. Yet despite mental health's pervasiveness, I think it's important to remind ourselves how and why we've got ourselves into the mess we've been going through for so long in the space of mental health. It's important to understand some of the things that are wrong, and so that we understand how to make things better and not make the same mistakes when rebuilding a human-focused system. For me, I think a critical component for a better future includes measures to address stigma and human rights. And I think these are fundamental to better systems. As many of us know too well, across the human services, the negative impact of stigma and the denial of human rights has been long and devastating. Failure in these areas has been devastating to one and all, and there's no doubt that it's diminished our society as a whole. And in many regards, we just haven't learned from these mistakes. Many of us in our everyday interactions would have observed or heard of systemic abuse, denial of service, and particularly damaging for those with no power and no means to seek redress. So really, when you're at the bottom of the heap, having stigma and denial of human rights doesn't allow you anywhere to go. And it's particularly devastating for those that are marginalised, isolated, mentally ill, drug affected or homeless. Collectively, we've watched trance-like as our institutional doors have shut on people's needs because of capacity problems or just plain old indifference to change the way things are. And that's observed not only in the health system, mental health system, our correction system, our AOD system. And over time, these behaviours have led to institutional acceptance and general public indifference to the plight of others. Yes, this has been a significant issue, not only just for those with mental health, but others, and I include my sector, the alcohol and drug sector as well. From my perspective, I'm fairly certain that a key reason why such systems and responses have been able to flourish is because there's been imbalances brought about by the impact of stigma and the denial of human rights. And as a result, we've suffered diminished capacity to access what they need through invisibility, marginalisation and demonisation. As we know, similar issues which beset those with mental health illnesses can to varying degrees and extents also impact Aboriginality, ethnicity, gender, LGBTQI status, homelessness and those with AOD issues. So the intersectionality of everything else. And just to illustrate some of these human rights abuses manifest within my own VAADA world and the AOD world over recent weeks, I'll give you a few examples of what I've been dealing with. An older woman denied entry to a hospital for a medical illness because of her alcohol addiction, being told to go home, dry out for a month and come back after that. A mother and child with substance use issues who is a victim of domestic violence, being denied refuge in a shelter because of addiction issues, left with limited options of homelessness or a return back to a dangerous home environment, which in fact she was forced to do. Individuals on pharmacotherapy having their doses dramatically lowered as a form of punishment. Dealing with issues of post-prison release, alcohol and drug deaths arising from inadequate community integration on release. Now, the coroner's inquest in findings recently looked at a cohort of about 212 coronial deaths. 90 of them were post-prison releases, people who had been prisoners. That's 40%. Now, in anyone's book, that looks like we've got a death penalty, by a de facto death penalty in our community, which we don't really care about. And what's only a too common occurrence, there's also people desperate for AOD treatment being placed on long waiting lists because of capacity issues, which on the one hand might be understandable, it simply isn't acceptable given what we've seen with AOD-related deaths in coroner's court figures year after year. And so within our community, our work, when it comes to stigma and human rights, we're currently dealing with the Wild West, and we need to bring some order into this. I would like to believe that the reform program built around the Royal Commission recommendations will be the basis for some significant re-environment of this issue. And let's hope that it's the basis of some positive social engineering, not just of the mental health system, but other systems which have also suffered from their brand of marginalisation. For example, the AOD system. Where we're heading might, if it's done properly, actually bring historic opportunity to break down the barriers of stigma, abuse and service denial. And despite the fears and insecurity that system reform may bring, and it does bring a lot of insecurity, these reforms have the potential to take us to a better place. By placing an emphasis on well-being, prevention and community-based services as the core, and with a heightened focus on families, carers, consumers with lived experience, it gives hope that a new foundation can be built, which is not only more relevant, but significantly influenced by a rights perspective and measures which radically reduce stigma. It's the fundamental needs of consumers, carers and families, along with the many dedicated staff that need to be the key drivers of the new mental health system. It's my hope and expectation that this desire for a new mental health foundation will also ensure many positive changes along the way for those with substance use issues as our system evolves as well. So thanks, Peter. I really appreciate the opportunity of speaking today.
Oh, thank you, Sam. Again, it really picks up on a lot of the recommendations and themes that are in the Mental Health Royal Commission, and we'll have questions later through the chat room for you. But you've really provoked a lot of thinking, I think, there, Sam. And thanks again. Now it's my pleasure to invite Simon Kroes from Nexus, not Northern Nexus, Simon, to speak to us now from a dual diagnosis service provider. And Simon is someone who's worked in the field for many, many years. I think you've been at St V's for about 13 years.
So I'd like to acknowledge the Wurundjeri people, who are the traditional custodians of the land on which I am speaking to you from today, and pay my respects to their elders past and present. Nexus, so my name's Simon Kroes. I'm a senior dual diagnosis clinician from Nexus, which is part of the Victorian Dual Diagnosis Initiative, or VDDI. Just for those of you who don't know, there's 4 metro teams. We've got rural partners, and we've been around for about 20 years, and we're vaguely divided up into northeast, southwest. Just my first point is people with mental health and AOD, so alcohol and other drug issues, are more common than not in treatment settings. So we're looking at more than about 80 or 90% of people that present to our treatment services will have both mental health and alcohol and other drug issues, and this has been widely recognised in the Royal Commission. And within the sort of theme in the Royal Commission around dual diagnosis is that mental health and wellbeing, treatment, care and support will be integrated with support for substance use and addiction, which is really, I think, really quite positive. More particularly, recommendation 36 is around having a new statewide service for people living with mental illness and substance use or addiction. And the new service is to be operationalised by the end of 2024. The Victorian Dual Diagnosis Initiative really looks forward to being involved in the planning and support of this service. We feel, as we've been around for about 20 years, we're very well placed to assist with looking at things like workforce development, the use of implementation science and so forth in terms of getting this recommendation up and running. However, there's already work being done, which is very much in line with the recommendations of the Royal Commission. At Nexus, we've been working on a whole lot of locally created workforce development instruments to assist staff when working with people who have mental health and alcohol or other drug issues. Some of the key projects, but there's certainly many more that Nexus have been involved in over the years, and I'll give you a link to our website near the end of this presentation so you can have a read of them if you want. But some key projects are the Reasons for Use package, the BDA, the Carers Can Ask, NEDI, and the Straight Up lived experience documentaries. The Reasons for Use package is a package to support, facilitate therapeutic conversations with consumers to explore dual diagnosis issues. It was created in 2011 and it's been rolled out across various agencies in Victoria and nationally. And we've got a growing evidence base for the usefulness of this. So I guess why I'm including these examples is because you've heard some of the macro ideas around some of the Royal Commission stuff. This is some more, I guess, practical ways of how do we implement some of the recommendations from the Royal Commission. The second package is the BDA, or the Before, During, After Harm Reduction package. This harm reduction was recognised in the Royal Commission as well. The BDA is a harm reduction treatment planning instrument. We've rolled it out again to numerous services across Victoria, and I use it personally at CAMS. There's a growing evidence base for the usefulness of this in mental health community support services, adult and youth services, the CCUs, which are community care units, and park services. Carers Can Ask, which is a big theme in the Royal Commission, was working with families and carers, and this is going to be a built-in expectation of government-funded mental health and wellbeing services. So it's really important to be including carers in the conversation, and this particular tool, which has been around for a number of years already, can assist your service to implement that. This can assist your service, roll this out, it can assist your service to comply with the recommendations of the Royal Commission. A simple, practical tool. It's been distributed very, very widely, this tool, and we've now got a project worker working on this, Carolyn Walters, who's fantastic, and she's developed an online course which was developed for staff, and that's pretty much ready to go now. And we'd also like to thank Lynn Ruggiero, who did a whole lot of work on this, who's done a whole lot of work on the CCA over a number of years. And we're hoping that this will be one of those practical, off-the-shelf kind of resources that staff and services can use, which will assist them to comply with the Royal Commission recommendations. We also run the North East Dual Diagnosis Network, the NEDI, which has been running for over 10 years. The aim of it's to develop best practice integrated care for young people who have a dual diagnosis in the North East. And this is a forum for workers to share ideas and practice wisdom, to look at essentially how we integrate services and how we look at improving our services for young people with both mental health and alcohol and other drug issues. The Straight Up resource are documentaries, because lived experience was a large theme in the Royal Commission as well. These documentaries explore the lived experience of people in recovery from mental health and substance use issues and their carers. You can use them straight away. They have learning guides attached to them. They're being used to enhance dual diagnosis training in industry and across a couple of different universities. Australian Catholic University and Monash University have been using these in some of their trainings. So I guess really from our perspective, what we think works is having clear tools. We sort of have this idea of we're sort of told what to do but not how to do it. And we think these packages will help people to do the work that is required of the Royal Commission. We found they are effective, but they need support for proper implementation. Training alone is definitely not enough. So it's about looking at how do we support proper implementation of these tools or other tools that are evidence-based. because basically a simple training sort of package is not enough. We need to think about things like, top-down management support, bottom-up support, how they're integrated into all the sort of logistics like staff rostering and, access to computers. All those sorts of things need to be thought about, and how do we actually roll them out so they are meaningfully sustained in the services, rather than sort of dropping in, doing a small bit of training and then parachuting out. Also, from our perspective, networks. Nexus is involved in a lot of networks, including this one, Yarra Drug and Health Forum. We strongly believe they're a really useful forum for getting integration happening. They're actually vital, but they need support. And that's not just about money, but it's commitment from agencies to put energy into them. So to allow staff to attend, to allow staff to engage in the projects that arise from these networks, that kind of thing. So just sort of finishing up here, I'm going to be reasonably quick and simple, but we're often told what to do without necessarily being given what the skills on how to do it. And we think that these resources, they're not going to fix everything. Obviously, they're not a magical cure, but they will help provide staff with the how. There's a resource there. Sorry, there's a link there to these resources. If you click on that, you'll be taken to all the various Nexus resources. Unfortunately, I've got to run a session in a couple of minutes, so I'm going to have to run. But if you do have any questions, this is our website, nexus.svh.org.au. That's a monitored mailbox. If you want to send any follow-up questions to that, feel free. And thanks very much for having me. Short and sweet.
Thanks very much, Simon, and really appreciate your presentation. And Nexus has delivered great services to the community via St Vincent's Hospital Base for many, many years, and we look forward to seeing how you guys end up through the rollout of the recommendations
so do
in
we.
the Royal Commission. Yeah, I'm sure you do. Thanks a lot. Thanks a lot, Simon.
Thanks, Peter.
Now, just moving right along, we've got a dual presentation now from Heather Pickard, who's the CEO of SHARC, and Sione Crawford, who's the CEO of Harm Reduction Victoria. And they're coming to speak to us from another perspective, and that is very much from the representing organisations that work with people with lived experience and have really worked in that space, supporting people and providing services from that perspective for many, many years. So welcome to you both.
Sorry, I'm just trying to find Heather. Is Heather still here?
Yes, thank you very much for that introduction.
Oh, there. Hang on, found it.
I think Heather's going to be kicking off our presentation, but first of all, I'd like to acknowledge the traditional owners of the land on which I am coming to you from today, the Wurundjeri people, and extend my appreciation and respect to our elders past and present who are here with us today as well. Heather?
Thank you, Sione, and I'll just add to that, I won't repeat those words, but just to acknowledge all diversity in all forms and welcome all people into this space today. Really cool to be here, really exciting kind of opportunity to come together, creatively put together by people who still want to have conversations even though we're working with different forums, so fantastic. Before I start, I'm just going to respond to a few things that were raised for Stephen, and I'll quickly go through this and then get to what I'm meant to talk about. Stephen talked about lived experience workforce and mobilising consumer footprint and leadership. And I just want to say that I was delighted to be part of the Consumer Foundation's working group during the development of the recommendations with the Royal Commission. And this is an absolute first and an absolute celebration of the opening of minds. It really is. We've never seen this before. We worked hand in hand with the work streams that were developed, and we're really part of the fabric of the development of those recommendations. So, I thought it was extraordinary. We did say that there should be a commissioner with lived experience, but maybe we'll see that next time. But a really exciting paradigm shift. And it was a very long and exhausting process, but really worthwhile. The other thing I wanted to talk about is Stephen raised somebody had asked about peer work, or we see it more as lived experience work in clinical or community spaces. Lived experience work is advocacy as well as peer work. So there are many different forms of lived experience workforce. And one of the things that we really need to do to enable this to be a successful rollout is get a clear understanding of the roles of peers or lived experience advocates or workforce. Training specifically to the lived experience workforce, or we're just going to roll out mini clinicians. Organisational readiness training, and there's already been a lot of this rolled out in the A&D, and it does my heart the world of good to be part of that journey. And discipline-specific co-reflection and network opportunities. So we don't increase our, lived experience workforce in mental health or drug and alcohol without including the supports they need. Really critical, and it's shown in the evaluation of the post-discharge support initiative from all those peer workers that were trained in mental health. So I just couldn't not say that, because I think that it's really, really critical. And I'll just have a mouthful of my tea. So I will now talk about what I was asked to talk about. Sione and I got together, and we've been working very collaboratively over the last year and a half, I guess, to really explore that sort of big bridge that people think is unwalkable between peer workers and lived experience workforce who work in harm reduction specialty areas and peer workers who work in the treatment space. And I think we've really traversed a good path, a good way down there. But one of the things that we found really interesting when we were thinking about opportunities for the Royal Commission was an often invisible cohort that tends to live under the radar, and that's people with current drug use and co-occurring with mental health. We don't often, where do these folk land? In homelessness shelters, in prisons, in crisis mental health settings. But a lot of the time, the folk that I talk to that fit into that cohort spend their time avoiding us as system providers because they don't want to be contained. And it's really critical that we do develop up some response that's helpful to this group of people. On asking these folks about why they don't pick up one of the suggestions that we often raise is that they're not ready for treatment or mental health. They kind of self-manage in some way with their own selection of drugs. And they also don't want to go into a restrained, high intense restrictive environment such as mental health has been for many years. They talk about stigma and also feeling like we're asking them to make a really clear decision, like you're either shiny clean going down the treatment trajectory or you're seen as a full-on drug user who makes that choice. So often feeling a lot of stigma about not making a clear choice. Another reason we hear is they're not familiar with our complex systems. My God, I had to help somebody through our complex system recently. And you know what? I've been in the sector for 29 years and I struggled to navigate that system. So we hear that a lot. Lifestyles that don't fit into our rules around access. Have you ever heard that? The rules about if you want to get into detox, you've got to ring every day at 8:00 in the morning to show your commitment. And I'm hoping we're not still doing that. In fact, I'm pretty sure we're changing that. But, our way that we bring people into our services is very mainstream and designed by us. The Mental Health Royal Commission is really exploring the opportunity to co-design in a true sense. It'll be interesting how we roll that out. So, our discussions was around what kind of a model could we put together for this group of people. And we also thought about, who would be the best workers. And for us, it was really peer workers with lived or living experience. And we felt that they were ideally situated to build a no-nonsense support quickly and effectively. And some of the reasons that our data shows us that lived experience works is, peer workers have a relational lens. So the ability to form a connection is, it's not higher than clinicians, but it's because it's a relational lens base, it happens more quickly and in a different kind of way. They talk about lived experience working for them because they don't feel judgment, and that the peer workers understand how it is. What is it like on the ground when you're not, you're trying to pick up your dome, you kind of want to get clean, you can't get your timing right to ring up the detox at 8 a.m. So a lot of the peers with living experience that are held in a safe way by the organisation that supports them. And the other thing that peer workers have is the knowledge of user-friendly GPs and user-friendly services and shortcuts and the ways to get the kind of help and support they need without being really decisive about it having to be one way or the other. So I'm nearly finished and handing it over to you, Sione, but we did a program proposal which is still being thought about, but we wanted to pilot a program targeting this particular cohort in which skilled and supervised peer case coordinators aim to facilitate engagement with health and social services and deliver a real person-centred service designed to actually help the person where they're at rather than what we might think a treatment plan should look like. I think back to when we had the Saving Lives initiative, those who were around 17 years ago in the sector. And what we did was we added primary health care to NSPs. And we did that because we wanted to have a non-judgmental opportunity for the human right of being able to access good health care despite the choice around what your drug use might be or might not be. And, that was also linked in with community. So we had councils and traders and police and AMBOs, and there was a funded package that looked at real community shift. And I know that we still have the primary health care response, but one of the sad things is we lost the funding for the partnership with community, and we really did see some significant shifts around reduction of stigma and willingness to look at the way the front of our services look. So I might hand it over to Sione now to talk about the model of care that we talked about.
Excuse me. Thank you, Heather. And look, I guess just to follow up on that last point, as we talk about this model, I think it is important to recognise that there are some great primary health care services that look after our community, and we partner with them in an ongoing way. And what we're talking about here in particular is about a peer-based response to go alongside that. And as Heather said, one of the core values of and valuable aspects of peer work is the engagement that we can undertake in a range of settings, not just primary health, although that's really important. I think I think it's really important to. I don't think it's useful to always to over dramatize things, but I think it's worth underlining the fact that the sort of work we're talking about is really about keeping people keeping a particular cohort of people alive while they wait for the AOD sector, the criminal justice sector, the mental health system to sort itself out, really. We harm reduction, as you all know, people involved in harm reduction is often thought of as the pointy end of things, and more we're incorporating harm reduction into other AOD services and primary health and so forth, and that's important and useful, but it needs to also be understood in itself as well, as an end in itself as well, and not just as a gateway to treatment access. And I think, as Heather sort of pointed out earlier, one of the key aims for this program is actually to honour the fact that people who have, for whatever reason, made a decision about not able to be being involved in intensive treatment, that they actually still have a right to access healthcare and to stay alive. And so this is really, when we put this together, it was a way of thinking about how we might do that. And so it's pretty obvious that a model that involved step care would be really important. So that's probably the first thing to understand, is that if we were to have harm reduction peer workers engaging with this population, we would need to be able to do both outreach and drop-in engagement and partnership with service providers, but to be really flexible and able to engage contact in a way that, I suppose, the community of people who are currently using drugs, and we are using the term living experience for that community at the moment, especially in the context of peer work, really the way that we operate in our day-to-day lives, right? So we often call this population hard to, well, we don't probably use this word anymore, but we used to be sort of called hard to reach. And for peer workers, we're not really, the population it's not about the population being hard to reach. It's about services not really being applicable for them. A consultation that we, HRVic, did during COVID, we did it on behalf of another organisation, well, in partnership with other organisations around a set of resources that we wanted to put together for the community. And one of the questions we asked was, what support do you think you need? And for the people that we accessed and talked to, a large proportion of them basically said we just want to be left alone, and not what we want is for this to be for our lifestyle to be decriminalised, because most of the issues that I've got are related to that, and this is sort of honouring that and trying to get past that and saying, okay, so what else can we do within that context? And so this model that we put together was based partly on a peer treatment support service model that I was part of in Canberra in the ACT, and CARMA is the drug user organisation up there, and really what that program is about. It's a different setup, and we've had to change it around a bit. But really, what that program is about was about holding people safely until they were ready to access other healthcare, whether that was primary health or AOD treatment or bloodborne virus treatment. And sometimes people were never ready, and we just provided them with support and care, for as long as they needed. But it is intensive and full on. But formally, the approach includes sort of, I guess, in words that we would understand, is AOD casework, education and information and referral and linkage to mental health services and AOD treatment. So not necessarily providing the clinical work necessarily, although that's feasible and viable in this model eventually. But in the first instance, we didn't want to overstep or get across our skis too much. Referral and linkage to primary care. But I think that what we've learned through our path, which is our Hep-C peer navigation program, that we've been undertaking in partnership with Burnett and Access Health and CoHealth now, is that peer workers, ideally in this context, really need really close relationship with clinicians such as nurses, and to be able to work really closely with them. So there is a limit, so there is not a gap. And one of the key things that we keep coming back to in this is that the waiting lists and the the gaps between wanting to make a change or make some or get some help in some way, and then being able to actually access it are just too long in our system. And for our cohort and the people that we're working with, it continually bounces them off the system and sets them back and back to year zero. And so working really closely and having a focused referral and linkage to care that isn't just the words, but actually thinking about how to make that as hot as possible is really important. Because of that, alongside it, we really need to undertake advocacy and support for these people to access the systems, because as we know, Centrelink housing, probation and parole, care and protection, that sort of part of our service system has a massive impact on our community for a range of reasons. And so being able to help them with those priorities so that they can prioritise healthcare would be a really key part of this work. And finally, absolutely support for people engaged in the criminal justice system is really important. I have a feeling I'm probably running out of time now, but I think that really just to summarise, we've got a list of sort of sample activities that we might think about engaging in, but that some of these sort of things, at least my experience in delivering this sort of service in the past, might range from sort of managing, like doing really intensive case management for someone through a range of settings like Centrelink housing, care and protection, but even down to providing transportation to a mainstream service so that they don't miss an appointment. Or maybe, to go back to the example we used, and I think some people in chat said that yes, people do still need to ring into services to show that they are still willing to be involved. Supporting them with things like phone calls, even, which I think we all know can, even if just a reminder to do the phone call, can be useful when someone has got multiple sort of competing priorities, and at any one time, making that phone call may or may not be the most important thing for them there and then. I don't think I'm telling you anything you don't already know, but it's really about coming back to the basics of harm reduction, which is about meeting someone where they're at and providing them with the services that are most needed right there and then at that time. And that might be NSP provision, it might be access to pharmacotherapy, it might be giving them a ride to a detox, depending on what it is or giving them, connecting them to the counsellor that's going to give them a ride to detox, whatever it is that works for them. That's the idea of this. And it comes back to the fact that our community the Path Peer Navigation program that we've been involved with at Access Health, one of the key learnings that came from that is just, and I suppose it was a surprise, even though it shouldn't have been, is that our the shared percentage of people with serious and acute mental health issues that impacted on their capacity to access other forms of treatment, healthcare, I should say, was quite overwhelming actually in some respects. And it really kind of highlighted the fact that we need some kind of peer-based harm reduction treatment service sort of support program for this population. We're definitely talking about people at some of the most pointy ends of our work.
Thanks, Sione. I was just about to jump in, my friend. Heather and Sione's passion is unrivaled in this space. And again, really important parts of the conversation, in fact, primary parts of the conversation. So I'm going to move on. Dr. Karen Gelb from the Penington Institute, I welcome you. Karen is a researcher and academic, and her submission written on behalf of the Penington Institute to the Royal Commission was outstanding. And I would encourage everyone to read some of the submissions that have gone in, but I reference yours, Karen. So welcome, Karen, and over to you.
Thank you. Thank you for your kind words, Peter. I'd like to begin by acknowledging the traditional owners. I'm on the land of the Wearne people, and pay my respects to elders past, present and emerging, and also acknowledge that this land was never ceded. I'm going to talk very, very briefly about the role of NSPs in the context of the Royal Commission's findings. I'm going to share my screen here so that you can have a quick look at the slides that I have. These slides are based on our submission, so it gives you kind of a quick preview of what we had in there. So we know that there are lots of service gaps for people who use drugs and experience mental illness. And I guess the question for NSP workers is, what can they do? How can they help? How can they play a role in helping their clients who experience both? The scale of the issue, we all know, is significant. We heard some statistics there previously about people who have the dual diagnosis. Research has shown that people who inject drugs in particular have very low life satisfaction across multiple domains, and lower even than people who are in prison. And there was one study that was done of NSP clients that found that basically almost all of them had at least one personality disorder, so a prevalence that's 14 times greater than in the general population. And you can see the quote there from the study that says this population has significant mental health issues, requires a comprehensive package of care. And it's the holistic models of treatment. So it's about looking at the person as a whole rather than just one or two components. During the consultations that I undertook while preparing the submission, our stakeholders were telling us about the large percentage of clients showing evidence of what they called accumulated trauma. So this was all sorts of trauma, including childhood trauma and particular circumstances, but also around relating to the overdose deaths of friends. But many of their clients wouldn't have had a formal diagnosis. And in fact, one person said to us, the mental health system doesn't exist for our clients. And a number of stakeholders said to us that they see that their role as catching people who fall through the cracks between the different systems because of those traditional service boundaries. A lot of people with whom I spoke about stigma and the differential stigma that is faced by people who use drugs and people who inject drugs in particular. And they made the point that mental illness is seen as being beyond one's control, but drug use is seen as being a moral failure. And someone said people fear what they don't understand. And so you end up with this inequity in the health system response that's based on the stigma. We all know about this. And someone said to us, what other reason would there be for prescribers to choose quite happily to treat someone's diabetes or heart disease or chronic obstructive pulmonary disease, but not want to treat their opioid dependence? So the question is, what can the NSP workforce do? And this was the question that we put to our stakeholders. One person was talking about a particularly disadvantaged client who had been released from prison and had all these co-occurring issues happening at the same time. And we've talked about prisoners being particularly disadvantaged. So no resources, no opportunity for employment or housing in both mental health and drug use issues. And that person had said to the NSP worker, this is the only place I feel safe, talking about the NSP, the only place that they feel safe. And that's really important. And it shows the value that NSP staff have in people's lives. But it's become harder for NSP staff to do more and more. I mean, there's sort of more and more that they're taking on. Their remit is expanding. There's, understanding and recognising family violence and being able to refer people for that issue. There's recognising and understanding and referring people around mental health problems. So there's a very wide remit now for people who work in the NSP sector, which means that they need to stay very informed. And in this context, informed around mental health issues, what issues look like, how they can manifest, how they manifest differently and impact differently for people who use drugs, which then leads to the need for, ensuring strong referral pathways so that each NSP site, that people there know their local services, know their local referral options. One of the suggestions that was made by several people with whom we spoke was about having some sort of short-term secondment or crossover days so that you have people who work in NSPs going to work or spending time with people who work in the mental health sector and vice versa. And we had the example from a woman who had the role of an AOD family violence advisor. And she said she spent one day per week with the family violence service to advise about responding to family violence clients who also had AOD issues. And a number of people talked about that sort of crossover opportunity. And this is a quote from a mental health worker who was invited in to an NSP for a day to spend time watching how the NSP worked. And the person said, I thought it would be really scary. So ways to break down those preconceptions. And my last slide about offering information to people who inject drugs in their families. NSPs do this all the time. Every small interaction, every brief interaction they have with people, they try to educate, they try and inform about harm reduction, how to access services, things like that. Then adding on information and education and support around mental health issues as well. Very difficult to do this when you've got seconds sometimes with people, but that's another way of bringing together the drug and mental health education and information. And we know that NSP staff are incredibly passionate. It's not an easy job to do, and yet they take it on. The challenge is that ongoing need to keep informed about the intersectionality, and a couple of people have already talked about this in this forum, the integration, the intersection across all those different areas, and maintaining links with local services in each of those areas as much as possible. And that's all I had. So thank you. I'll stop my share.
Yeah, thanks, Karen. One quick question. How prominent was the regional voice in that work that you did in surveying NSP workers?
I spoke to a number of people in regional areas, probably 5 or 6. I spoke to an Aboriginal regional service. I spoke to people who work with forensic clients in the regional areas. So I spoke to across the state.
Yeah, fantastic. There was just a question asked. I thought I'd get that up before we lost the opportunity. Thank you. Now, Tricia Szirom, it's over to you. Now, Tricia has been a legend in the AOD sector. I remember when Tricia was the head of Drug Treatment Services Victoria for the Department of Health back in the old day. It's Department of Health again. And Tricia has had different roles as running her own private consultancy, also working for the Brotherhood of St Lawrence, and currently she's the joint CEO of VMIAC, which is an advocacy organisation in the mental health area for people with lived experience, and works in partnership with a number of different organisations across the state. So welcome, Tricia.
Thank you, Peter. It's nice to see you again.
Good to see you.
After all these years, I was actually the person responsible for taking alcohol and drugs out of mental health. So it's ironic for me to see it coming back. There were very good reasons at the time for taking it out. It was totally dominated by a psychiatric model. And as a consumer organisation, we are still concerned about the dominance of the psychiatric medical model that is patriarchal and misogynist. Before I say anything more and get on my other soapbox, I would like to also acknowledge the traditional owners of this land and add to the other things that have been said, that this land was not only not ceded, it was taken violently. And we acknowledge and recognise the Uluru Statement from the Heart and thank the Indigenous people for their patience and persistence in caring for this sacred land. I'm going to talk very briefly, because I could talk for hours, having scanned through the Royal Commission report. I'm going to talk about what we're hopeful about with the Royal Commission and what still gives us concern. And I'm doing it from a mental health perspective and hope that it is of relevance to the alcohol and drug sector as well. The thing that makes us most hopeful is that the commitment has come from the very top. The Premier has said that his government will implement every recommendation of the Royal Commission, and they will fund it all with what I think might become an unpopular levy, certainly unpopular with the opposition. And so there are a number of things that we think give us hope. The first one is that the Commission and the Premier acknowledged that the system was broken, and severely broken to the extent that it is currently damaging to the people who use it and to the people who work in it. And I think that was a huge acknowledgement. If you don't admit something's broken, then you don't bother to fix it. And so we recognise that there is some hope in the fixing. One of our big concerns is that the vision of the Commission will become bureaucratised and will not be visionary in its implementation. That is a key issue for us, and we are already concerned that some of the things that the vision of the Royal Commission's talked about will not be implemented in a way that actually shifts the paradigm. Two of the things that really give us hope, aside from those, is that the Commission talked about social determinants of mental health. And this is not something that's been discussed a lot in the mental health sector, and it certainly hasn't been seen as a part of a model for treatment or healing. And so we're very enthusiastic about some of the research that is around that says if you deal with the social determinants, you can cut the mental health or the mental illness rate by 50%, which is a very dramatic piece of research. And so we know, as all of you know, that most of the people who are homeless have a mental illness, and those that have a mental illness end up being homeless. And if you consider trauma as a social determinant, then you add to the issues and you add to a new thinking about possible solutions. And in healing, and if we talk about healing instead of treatment, then we also look at a new paradigm. And they are really important conversations that we need to be having. How do you bring about healing? How do you use social determinants as a way of considering healing? The second thing that we are really positive about and hopeful about is that the Commission has said quite strongly that consumers must be at the centre of every aspect of the implementation, the rollout, and the new paradigm. We are also concerned about this because recently we've been doing some work with peer workers, and we don't just see lived experience and consumers and their involvement as being about peer work. We see it at every single level of the system. However, if you start with peer workers, one I talked with the other day works 2 days a week, not enough to pay her capacity to live. So in the mornings, she sits in the waiting room with people on their way to ECT, which is an extremely traumatic experience for her and for the people going into ECT, and in many, many cases for the people who administer it. So that's just a small indication of what happens for peer workers. I spoke to another one just recently who has been working in the same job for 10 years and has never once had professional or discipline appropriate supervision. In a new program that's been developed, providing peer supervision for lived experience workers, She said that was the first time she understood what a peer worker is supposed to do. And that's tragic. The government is spending money to support people who have, as you described, living experience. I love that phrase, Heather, because it doesn't deny that our experience is not just lived, it is living, and we carry it with us every day. So those things give us hope. Some of the things that really concern us, and look, I could speak on some of this for hours. Some of the things that really concern us is that right now, the Mental Health Act is being rewritten. However, unfortunately, the Commission did not deal with some of the real harms that are embodied in the Act. And one of these is seclusion, and the another one is constraint. We do a seclusion report every year, and we're just going into our current seclusion report. And we know hospitals use seclusion and constraint, both physical and medical and chemical constraint, in ways that are totally inappropriate and not related to healing at all. And so the concept of healing and treating people with medication and with constraint and seclusion is counterproductive to good healing. So two of the things we're really pleased about are the development of a peer service, a peer-run service based on a model that was developed in New Zealand a few years ago, where it is totally run an acute system that will take a small group of consumers and be run totally by consumers. The second piece of work that's being developed at the moment is what's being called the Collaborative Centre, which will be co-led by a clinician and a consumer, and will have in it, many of you will have heard about it, but we're very positive about the potential of this new service, this Collaborative Centre, which will integrate and develop translational and transitional research and practice, and then provide education into the system. Very exciting possibilities. And that goes back again to the importance of the consumer workforce. And along with Heather, I was in the working group, the Consumer Foundation's working group to the Commission, and we were able to talk to them about what needed to be in place for the implementation to be true to the vision that they held. And one of the other things that is being developed is the Mental Health and Wellbeing Commission, which will have at least one, and we're arguing for at least two, consumer commissioners who will be able to look at what is happening across the system, hold the government to account for whether it does implement, and more importantly, in some ways, hold the system to account. At the moment, it is possible to have people in seclusion. It is possible to re-traumatise people who go into the system already traumatised and then are re-triggered by the inappropriate treatment that they get. And they are not, while they may be complained about, they are not held to account, and they're not encouraged to hold themselves to account, except by a couple of small processes. And we are very, very hopeful that the Mental Health and Wellbeing Commission will actually help shift the paradigm away from a medical model, a psychiatric model, to a model that is about community engagement, that is about consumers having some aspect of control over their own treatment, and some ways of shifting the way the stigma and discrimination works against the healing of the people that we work with at VMIAC. I'll stop there, I think, Peter. Thank you.
Thanks very much, Tricia. And look, we've gone over time and it was hard to cut anybody off today because it's all so rich. A lot of the questions that have been asked have really been around, particularly around peer workers and the valuing of peer workers within systems. And some of those questions have been addressed. And I think, Tricia, you've really nailed it at the end about what the opportunities and what the dangers are in this process. And so rather than keep it going because people are dropping out because of time restraints, firstly, I'd like to thank everybody for their presentations. These presentations are going to be recorded and available on our website. But also thank you for your commitments to the sectors that you are working in and are serving. And I think it's really inspiring because Trish used to scare the living daylights out of me when I started at Wassels. And she was a fearsome bureaucrat in all the good senses of that word. But most importantly, the people here have demonstrated a lot of reasons we should be hopeful. There's some really smart, committed people in our systems wanting to work together and hear the voice of people with lived experience. And from Penington to VMIAC, to Nexus, to VAADA, to Harm Reduction Victoria and service organisations like SHARC and others, there's amazing resources here. And I want to acknowledge all that and just thank you all very much. And sorry it's gone over time, but this is all going to be available on our website. And I just want to, again, on behalf of everybody, we've had over 60 people join in today. Thank you very much for your presentations and many more will see them. So on behalf of the forum, thank you. And remember, look to the recordings. I'll be watching them again, that's for sure. So thanks again, once again to everybody. Cheers. Have a great day.